Good morning, everybody. Good afternoon, Dr. Shetty. Can you hear us?
Hi.
And we're just going to get the volume sorted out at this end. Just bear with me 1 second. You can hear us well?
Yes, I can hear you very well.
Great. Thank you, Dr. Shetty, and we can hear you very well, too. Good afternoon there, good morning here, and welcome to New York. Thank you so much for making time out of your busy schedule to join us here. This forum has been looking at the future of health system strengthening and the particular role that public-private partnerships may play in that. And it's a great pleasure to welcome you to join us here today. For those of you that don't know, Dr. Shetty is chairman and founder of Narayana Health, one of India's largest and world's most economical healthcare service providers. I'm not going to tell you much more about it because we're going to hear it directly from Dr. Shetty. But I think one of the things that is really incredibly exciting about this is the ability to reconcile quality, affordability, scale, transparency, credibility, and profitability as a potential global model to go forward. I think, Dr. Shetty, in an email to us, you said there's no other way. So with that, a great welcome. We look forward to your presentation and an opportunity to ask some questions after. So with that, please let me hand over to you.
Thank you very much. Thank you. Good morning to all of you. I'm extremely grateful to the organizers for giving me the opportunity. The topic for discussion is about cardiac surgery for $800. And we are not anywhere close to it, but that's our ambition. Today, heart surgery in our hospital costs between $1,400 to $1,600 from the point of admission to point of discharge. Next slide, please. This is the hospital where I am based. I'm speaking from here. It's a 3,000-bed health city with 4 hospitals in one complex. The front building is the heart hospital, which can accommodate up to 1,000 heart patients. We have 23 operation theaters dedicated only for heart surgery. We can go up to 60 major heart surgeries in a day. We do currently about 27 to 35 heart surgeries every day. We have 30 hospitals across India, and 12% of the heart surgery done in India is done by our group. Next one, please. I would like to reiterate that economy of the 21st century will be driven by health sector, because this is one industry which can create maximum number of jobs which is desperately required. Global healthcare and wellness industry is a $7 trillion industry. It is the second largest industry in the world. Unfortunately, the policymakers do not understand the employment creating ability or the ability of health sector to drive the global economy. Next slide, please. We have been working very closely with our government, state government, for the last 15 years. And 11 years ago, there was drought in the state of Karnataka, where I work. So we convinced our government to launch a health insurance for the poor farmers. The idea is that every farmer pays 11 cents per month, and government agrees to become the reinsurer. And at the end of 10 years, 710,000 farmers had varieties of surgeries in one of the networked, we have 400 hospitals across the state where these farmers can get the benefit. And now it is over 95,000 farmers having undergone a heart operation. All this happened by 11 cents per month. In the first year, we had 1.7 million farmers paying 11 cents. Today, we have 4 million farmers paying 22 cents per month. Now, we are convincing our policymakers. We have close to 900 million mobile phone subscribers. and we would like to collect about every month about $2 or $3. So this is a good enough money for us to, sorry, it's not $3 a month. It is 20 rupees will be, 20 rupees will be about half a dollar per month. That is the premium we are looking at. If we can collect half a dollar from 900 million mobile phone subscribers, we believe that 900 million people can be covered for surgical treatment. It is possible. Poor people in isolation are very weak, but together they are very strong. Next slide, please. We believe that India will become the first country in the world to dissociate healthcare from affluence. India will prove to the world that the wealth of the nation has nothing to do with the quality of healthcare its citizens can enjoy. For all this major transformation to happen, we need to build different type of hospitals. We have 100 towns in India with a population of 500,000 to 1 million, where there is no super specialty hospital for heart surgery or a brain operation. They can't afford a hospital which is built with the traditional manner. So we worked with India's largest construction company to build and equip a 300-bed super specialty hospital for $6 million. And we wanted to build it in 6 months. Normally it takes about $25 million for a hospital of this size in India, and it takes about 2 to 3 years to build. So we want to do it for $6 million, and we want to do it in 6 months. Next slide, please. And we built such hospital. It was built about a year ago, and the hospital is doing extremely well. We ended up spending $7 million. We couldn't build and equip within 6 million. And we took 8 months to build. We couldn't do it in 6 months. But our next project, we believe, can be done within $6 million in 6 months. Next slide, please. I'm just giving you some of the examples what we have done to reduce our cost and make it affordable. Whether a patient gets admitted for a heart operation in US or in India, the family members are not allowed to participate in the caregiving process in the hospital. A typical patient of ours is a 50-year-old man, gets admitted to the hospital. His wife stays with him. But throughout his stay, she is not allowed to touch him in terms of taking care of him. But exactly 4 days after the heart operation, we call the wife, give her one plastic bag with all the medicines, and ask her to take care of the husband. Now she is lost because she doesn't know what to do with him. So around 4 years ago, we launched a program called Care Companion with the students from Stanford Business School. We gave them a target to create a curriculum, which is a short film of 1 minute each, teaching 12 tasks to the spouse to take care of the patient in the hospital. We taught the spouse how to record the blood pressure, how to record the pulse rate, how to do the wound dressing, medications on time, physiotherapy, and these fundamental things we taught them. And interestingly, they did a fantastic job, and our readmission rate came down significantly, because when the spouse was there with the patient at home, there was a continuity of care. And 5 months ago, British Parliamentary Commission chose our program, Care Companion, as the best patient empowerment tool. And all this happened without spending any money. Next slide, please. The incidence of bed sore following heart operation across the world is 7% to 40%. Around 4 years ago, we sat with the nurses, we told them that we have to eliminate bed sore. And we wanted them to come up with a process change. But the only difference is, when a bed sore happens, we want them to identify a nurse who is responsible for the care when the bed sore happens. So generally what happens, a patient gets admitted to the ward. If the ward nurses do not take care of the patient well, the bed sore starts in the ward, then he goes to the operating room, then he goes to the ICU. By the time he comes back to the ward, he has a full-fledged bed sore. And when you inquire, nobody is taking the responsibility. So because we told them that one person has to be accountable, the ward nurse will ensure that all the pressure areas are okay. There are only 5-6 pressure areas where bed sore can happen. So they ensure that area is healthy. When the patient comes to the operation theatre, our OT nurses looks at the pressure sore just to make sure that it is okay, and the ward didn't give the bed sore. Each one is trying to pin the responsibility on the other person. And from the operation theatre, when the patient goes to the intensive care unit, ICU nurses inspect the bed's pressure areas just to make sure that he did not come from the operation theatre with a bed sore. So by making this, and whenever they are suspecting some problem, with the hand camera they take a picture as an evidence. By doing this, in the last 3 years, over 3 years, we eliminated bed sore completely. We didn't reduce it by 50%. There is no bed sore. We do the largest number of heart surgeries in the world, and we rarely get 1 or 2 bed sore in a year. And this process of theirs is published in American Nursing Journal. The slide here is a copy from the American Nursing Journal. Now, quite a few hospitals in Europe and US are following this protocol about pinning the responsibility for an event. All these changes we have done with significant impact has happened without any investment. What we noticed is, when you have a lot of money in the bank, your brain stops working. Next slide, please. 99% of the hospitals in India still use linen as for the surgeon's gown and for draping the patient. Linen is not very safe because it's difficult to clean. But disposable gowns and drapes are expensive. So we negotiated with 2 multinational companies to give us the disposable gowns and drapes for a heart operation around 3 years ago. And they wanted us to pay them 5,000 rupees. 5,000 rupees is approximately I think about maybe about $20 or $30. I am not able to convert it. So we wanted to pay them half the money, but they refused to come down on the price. So we got hold of the local young entrepreneurs, some business graduates, and we told them that these disposable gowns and drapes can be easily made because we have a lot of garment workers, young ladies who can stitch very nice suits. So they can easily stitch these gowns and drapes. And the material comes from a company called Alstom. And this is how a company called Amiralis was created. And they reduce the cost of disposable gowns and drapes to less than what it costs if we use the linen. And they have a CE marking. That means they can export this to virtually most of the countries. They are in the process of getting US FDA. And they believe that they can reduce the cost of these gowns and drapes for the entire heart operation to about $10 or less than $10 per piece, per operation. So essentially, all these changes can be done without compromising on the quality, because when somebody makes this product, they get 12% of the Indian market. This is our strength. Next slide, please. We invest heavily on technology to monitor everything what we do. We have an Oracle ERP on a cloud. Every day by 12 o'clock in the afternoon, the senior doctors, senior administrators get a SMS on their mobile number with the previous day's revenue, expenses, and the EBITDA margin. It's very important for a hospital to look at the profit and loss account on a daily basis. For us, looking at the profit and loss account at the end of the month is like reading a post-mortem report. Patient is dead, you can't do anything about it. But getting the profit and loss account on a daily basis is a diagnostic tool, and it helps you to make right decisions. Next slide, please. One of the biggest problems affecting every country in the world is the shortage of doctors. Unfortunately, today, children from poor families in India do not dream of becoming doctors because of the presumed high cost of medical education. So we launched a program called Uday Pate in West Bengal with the intention of getting 2,000 children from villages of West Bengal to join medical college every year. These children, when they are 13-year-old, should commit to us that they will become doctors. Then we give them a scholarship of $10 a month and we mentor them. We organize a student loan for them and we help them to get into the medical school. Now, why is it important that children from poor families should become doctors? It is important because we have observed that the outstanding doctors across the world who have got magic in their finger generally come from deprived background. Because these kids from the deprived background have the fire in the belly to work for 16 to 18 hours a day and change the rules of the game. If the medical education is expensive, these children will stop dreaming of becoming doctors. That will have a big impact on the quality of healthcare a country can give in the years to come. Next slide, please. We are very concerned about the risk involved for a patient when he is getting treated in the hospital. This is predominantly because I am just giving you two cover pages in 50 years apart. 50 years ago, the Look magazine had Jacqueline Kennedy's face, and the lead article was, "Our hospitals are killing us." 50 years later, Forbes magazine had a similar article about how safe American hospitals are. US hospitals are some of the safest hospitals on the planet. But if 200 patients get admitted to an American hospital and they spend just one night, one of them will die due to medical error. It is not medical negligence. It is medical error. Getting admitted to an American hospital is 10 times riskier than skydiving. Why this happens? It happens because doctors do not follow the protocols. Every hospital has a protocol, but it is nicely kept in a bound file inside the cupboard. We believe that the next big thing in healthcare is going to be information technology, which will change everything what we do in healthcare. And information technology will reduce the mortality inside the hospital by 50%. It will reduce the cost by 25%. And we believe it will help us to penetrate healthcare to 100% of the population. Next slide, please. So we are not talking about big data. There are only 6,000 diseases, and there are only 1,000 diseases are common. There are only 100,000 signs, symptoms, and lab tests. Even the mobile phone software can come up with a diagnosis of matching the signs, symptoms, and the disease. Next slide, please. So we are using technology heavily. The person you see is a pharmacist. He is paraplegic. He is bedridden. He is on a wheelchair at home. And we have connected him to all the patients who are on warfarin. When they go home, they need to check the warfarin INR every month, and they need to talk to a doctor. And in rural India, it's very difficult to see the doctor, but they all have a phone. So this patient, who himself is a patient who had a valve replacement, he knows what is the right dose for the INR given. We also worked with the Stanford University and developed an algorithm to help him. And he manages the INR of few thousand patients. Every day he gets 300 to 400 calls, messages, emails, and he attends to them. And this service is offered entirely free. Few thousand people are alive in Asia and Africa because of his service of timely advice. And it only costs us hardly about $500 a month to maintain his service. That's all it costs. Next slide, please. We have invested heavily on technology to replace all the charts in the ICU. This is the iPad, which has a built-in protocol, and that manages the post-op cardiac patient. It's a software we created called iCare, which is very intuitive, which doesn't require any instruction manual. Nurses do not undergo any training program. It is very self-intuitive. Next slide, please. We started online clinic because we believe that most of the outpatients of every hospital will disappear within the next 5 to 10 years. Patient will see the doctor online. So I'm not sure how many of you use an app called WhatsApp. WhatsApp is an app and a smartphone which is very, very popular. And we have a young diabetologist, a young lady diabetologist. She manages the diabetic problem of few thousand patients using the WhatsApp. A typical patient calls her from the distance, from home. She takes a history and she writes a history, and then she takes a picture of the history. And now she has a EMR and the patient has a EMR. Next slide, please. And if she wants to see how big the patient is, the patient sends a picture. Next slide, please. And when the diabetologist wants to know what medication patient is on, the patient takes a picture of the medications on the phone, and then she gets to see the medications and the prescription. Next slide, please. But the beauty is diabetologist staying at home, taking care of her child, She doesn't want to work in the hospital because of the child. But from home, she can work from 6 o'clock in the morning till 10 o'clock at night because she has nothing much happening. She's very happy to offer her services. Like her, we have thousands of pediatricians, we have thousands of dermatologists, young doctors staying at home, taking care of the children, and if we can give them a suitable technology connection, they will be able to offer diabetic care or a pediatric care or a dermatology care for whole of Asia and Africa and Latin America. Next slide, please. So we are also investing on creating a simulator to train the nurses to manage a cardiac patient in the ICU. We believe that whether it's an American hospital or an Indian hospital, all the ward beds are going to disappear. We need to train few million nurses who are taking care of the ward to take care of the patient on a ventilator. How do you train them? If you don't train them, they are going to lose their job because wards are going to disappear. But number of ICU beds will increase 1,000 times. So we thought we should use a simulator to train them. So we are creating low-cost simulators. Next slide, please. Just want to reassure you that we are one of the case studies at the Harvard Business School for the last 7 years. Next slide, please. And we were also, next slide, on the cover page of Wall Street Journal. Just to reassure you that whatever I was talking about, there is some authentication. Next slide, please. This is the hospital we built in Cayman Island. This is only, as you are aware, Cayman Island is about less than 45 minutes to an hour from Miami Airport. Our intention is to build a 2,000-bed health city in Cayman Island. We started with 150 beds, and in less than a year, we managed to get the Joint Commission accreditation to this hospital. And we have already implanted 2 artificial hearts on the patients in this island. So essentially, we are very, very bullish about the healthcare opportunities across the world, and I'm extremely grateful to you for giving me this opportunity. Thank you very much.
Debbie, thank you so much for the presentation. Really appreciate it. Let me open the floor and see if there are any questions, comments. Yes, please go ahead. Elaine.
Hi, Elaine Gibbons from PATH Global Health non-profit organisation, and I actually spent 2 years in Bangalore in a previous role, and so I'm very familiar with the hospital. So nice to talk to you today. What do you think are your major barriers to scaling this operation?
I think the basic problem we have in India is going to be the capital, because the capital is a very scarce commodity, and when we find the capital, eventually it is going to be the skilled manpower. I think global healthcare will reach certain level and it will stop because of shortage of doctors, nurses and medical technicians. Unless we dramatically change the way doctors, nurses and medical technicians are trained, the entire world will be in trouble, and US and Europe is not going to be an exception.
Good morning or afternoon, evening. Thank you very much. It's a really interesting presentation. My name's Jo Buford. I'm the co-chair of the panel. I wanted to ask, I guess, 2 questions. One is that many of the patients with heart disease also have other serious chronic illnesses. You mentioned diabetes, occasionally cancer, pulmonary disease, and others. And the model you've designed appears, and I know you haven't had time to go into it in detail for us, but appears to be quite is segmented and focused, which gives you a lot of the economies of scale and training and ordering materials and building and other things. Could you talk a little bit about sort of multi-problem patients or patients with multiple diagnoses and how that fits into your training model and your sort of purchasing design model for the sort of cardiac care piece of this?
This is the health city where I'm working. Behind our hospital, we have a 1,000-bed multi-specialty hospital with cancer as the main specialty. Then we have another orthopedic hospital and eye hospital. So all these specialists are available in the same campus. They're located in the same campus but in different buildings. And we get support from the nephrologist, neurologist, and urologist, whoever you want. They're all available in the same campus. We never build a standalone heart hospital without the support of the other systems. And most of our patients have many comorbid conditions. In England, a very small percentage of my patients had diabetes as a comorbid condition. In India, more than 50% of the patients have diabetes as a comorbid condition. Along with diabetes, they have multiple other problems. So we have support systems here.
Yeah, and just one follow-on on your model. Can you describe the role of community-based direct care services? You've described very well the online supports, but patients needing to see sort of primary care or following up with an in-person caregiver, closer to their own home, not quite able to be managed virtually, or is that not an issue?
We are aggressively reaching out to people. I wish I had a slide. We are trying to create few thousand primary healthcare centers. In India, it's called PHC, Primary Health Centers. This is a very simple model. It is suitable for rural India. What we have done it in now about 20 locations. We buy the shipping container, a condemned shipping container which comes free of cost. And we air condition that and we start a clinic inside that. But it's a clinic which is paperless. Hewlett Packard, HP is our partner. They provide the technology support. And we have a nurse practitioner or a physician assistant sitting there. He is a primary healthcare provider. We do all the blood tests in the same clinic using dry chemistry. And some clinics have, we are in the process of adding digital X-ray. Essentially, all this can be done in large scale by using the shipping containers. So we are aggressively reaching out to people.
Thank you very much.
Please, go ahead.
Hi, Dr. Shetty. My name is Meha Pandey-Chiraya, and I'm a consultant with Accenture Development Partnerships, which is a not-for-profit arm of the consulting company Accenture. And my question for you is related to the theme of partnerships. So as you may know, this conference here is really focused on some best practices with partnerships. And it sounds like one of the secrets to your success has been engaging with local and global partners, whether through business schools or with local social entrepreneurs. So I'm curious to know what are maybe some of your top 3 lessons learned from these experiences, and how do you engage in these successful partnerships?
We have been investing on partnership for a long time. First, we had a long-term association with medical equipment companies. Then we started expanding into the partnership with the governments. The hospital we built in Cayman Island is built in partnership with Ascension Health of US. They are our partners. And now we are trying to work with 2 of the US hospital chains to build software solutions for delivering healthcare back in India. We have developed a lot of tools to streamline healthcare services, and these tools have become extremely successful. one of our young residents developed a app called Surgeon's Logbook. He would have spent hardly a few $100s and built this app, which is important for all the young surgeons when they undergo their training program. They need to enter all their data. And he wasn't happy with the existing logbook, and he developed this, and he put it on an app store. He put it in a Play Store, and in less than 3 months, it became the most downloaded surgeon's logbook in the world. So we have phenomenal, talented people who can make amazing tools for delivering healthcare. So we are in the process of tying up with some US partners. Essentially, going forward, it's going to be the cooperation, not competition.
Yes, Dick.
Hello, I'm Dick Garant at the University of Virginia Division of Global Health Center there. This is an extraordinary story that you're telling, and it's hardly fair to expect you to help us cope with primary care health delivery questions, but you are doing it. And to extend Dr. Beauford's question a little further, in the primary care area, you've engaged people in their homes for care in the hospitals and follow-up of their anticoagulation. Have you engaged the equivalent of community health workers in this kind of follow-up or in primary care? And second question, have you gotten information from the patients about follow-up information, satisfaction, outcomes?
Thank you very much. About the second question, let me answer first. We have developed a technology solution for following up the patient after the operation or discharge from the hospital. It's a simple app. It is called BOL, B-O-L. BOL in Hindi is to speak. You can download that app from App Store or a Play Store. It's free. So essentially, when the patient goes home, we expect them to download it, and they can send a voice message to the doctor, whoever has done the operation. Because doctors don't like to take a call from the patient, but they don't mind getting a voice message. So also, when the doctor wants to convey the message, they use this technology solution. Essentially, we want to be in touch with the patient, irrespective of where the patient is, whether he is in the hospital or at home, using technology. This is the way communication will happen in the years to come. It will be voice-based communication, not texting, because 1 minute of voice message, if you have to text it, it will take you 25 minutes. And in voice, you can convey the emotions. So these are the technology solutions we are coming up with. And about the involving the social workers, we have few 100,000 social workers in India working for the government. We have multiple programs with them. One of the programs we have is early detection of oral cancer. 30% of the cancer in India is head and neck cancer because of the tobacco chewing habits. So we train these ASHA the social workers who are working in rural India to take a picture of a suspicious lesion in the mouth and send it to us from smartphone. And we go analyze, our experts analyze it. If you are in doubt, we organize the biopsy. So we are coming up with all this technology solution to reach out to the community. We are in the process of working on reducing the maternal mortality. This is the technology solution created by Philips. They have handheld ultrasound, which can do the ultrasound at home. And we can train young doctors to do this. And they have an app which can do the risk stratification of the pregnant ladies. So there are multiple things we do to improve the community health using technology, because we want technology should be the foundation of delivering healthcare so that it can be easily scaled up.
Thank you. Let me just take one more question. Bob?
Thank you very much. Wonderful, wonderful story. I have a question, follow-up question about your the public part of your public-private partnership and your relationship to the government officials you talked about. In many parts of the world, other than India, it's been a challenge to get privatized healthcare to serve the needs of poor communities, so I congratulate you for that. But have you seen any issues as you expand this model where you are, there's concern about competing with the public sector for the best doctors, the best nurses, for resources? Are there concerns on the state level or the federal level for investing or reducing investment in public services when the private services become the go-to place even for the low-income population? I mean, I think it's wonderful what you're doing, but I'd be interested in how you're negotiating some of those challenging conversations, perhaps.
There is really no competition, predominantly because our government spends 1% of the GDP on healthcare. Just 1%. And with 1% investment on healthcare, government can hardly do anything worthwhile. So over 75% of the healthcare in terms of secondary and tertiary healthcare is offered by private sector. And we believe that it will only get better and better as we have more and more number of beds, as we train more and more doctors and more specialists enter the scene. So there is definitely a friction in terms of we launch schemes with the government, then the government becomes a payer. And when the government becomes a payer, there is always a delay in the payment. And also we don't have control over how much they pay for the procedure. Having said that, we cannot work in any part of the world without the government. They are integral part of the ecosystem. So we have to constantly learn our way how to manage with the new policies and the new government initiatives. It is going to be a challenge for us, for you, for everybody. Government wants everything to be done free of cost, and they don't want to pay. That is a problem. And they don't want to pay because they have no money. But they can make rules. They can make regulations, which we have to follow.
Great. Dr. Shetty, thank you so much for your presentation. I think there's lots and lots of food for thought there. You talked a lot about technology and technological innovations and the way of the future, but you've also talked about other innovations beyond technology, which was a feature of a conversation we had yesterday. We also had an analogy yesterday of sustainable business models, thinking about smartphones, how they've got smaller, faster, smarter, and cheaper. And we need that same sort of development business model for healthcare, making it smarter, faster, better, and cheaper. And I think there's one slide you didn't get to, which says the cost of healthcare in the first world countries will only come down, or will not come down until healthcare is affordable to the common man of the third world. And a lot of what we're thinking about is how we prevent people being left behind, how we provide services in more effective and innovative ways to those people that get left behind. And I think you've got some fantastic stories here for us to dwell on and think through. So if you'll all please join me in thanking once again Dr. Shetty. Thank you very much, sir. Thank you, Dr. Shetty. I hope to talk again.